Good afternoon, colleagues and friends. I'm very pleased to have opportunity to give a talk here about advanced universal health coverage in Asia, what we can learn from each other. I do appreciate the kind invitation from Shanghai Forum to be here to see lots of older friends and new friends. So what I'm going to talk today is what is universal health coverage, major development of universal health coverage in developed countries, and good practice and lessons learned from implementing the global universal health coverage and their implications for Asia. Recently, Dr. Margaret Chen, the Director General of WHO, she said, universal health coverage is the single most powerful concept that public health has to offer because it is a mechanism to implement the right to the health and to implement the equities. So at the moment, we all know that universal health coverage or universal coverage of healthcare is a very hot topic globally. Lots of countries, particularly in the lower middle income countries, have developed key strategies, policies to advance universal coverage of healthcare for their peoples. So what's the definitions of universal coverage? I obviously asked one of my students who did a literature review, and he came up with a variety of the definitions. But given the time limited, I just quote the definitions from WHO and definition from World Bank. So in 2005, the World Health Assembly passed a resolution, and the resolution defines universal coverage as access to key promotive, preventive, curative, rehabilitative health intervention for all at affordable cost, thereby achieving equity in access. So the principle of financial risk protection ensures that the cost of care does not put people at risk of financial catastrophes. So that's the definitions used by the World Health Assembly's resolution endorsed in 2005. And the World Bank has a much simpler definition about universal coverage. Universal coverage with health care insurance function may be defined as physical, financial access to necessary health care of the good quality for all the peoples in the societies. So these are very similar definitions about universal coverage. There are two broad of the category of meanings about universal health coverage. One is by the Institute of Medicine in the United States. Universal health coverage has been used to mean everybody should have health insurance because health insurance has been used in the United States to help the people to get access to health care. There are a variety of scholars, authors develop other a category of meanings. That means universal coverage means that all needed medical services should be available at low or no cost from perspectives of service users, of insurance or government tax-based schemes should pay for it. For me, I think universal coverage is development issues. It's not just public health or health issues, it's development issues. We know people who are ill and unable to work can be pushed into poverty. Lots of studies conducted in China or as well as other countries show that due to the high Medicare cost, particularly out-of-pocket payment, people always often be put in poverty due to high expenditures on health care. Likewise, and the ability to work and earn can lift people out of the poverty. If people healthy and more energetic, and could work hard, get money, and they could actually lift it out of poverty. So good universal health care protects people from illness, stimulates economic growth. We now know, macroeconomic health, commission report published by the WHO demonstrated the good health could facilitate the rapid increase of economic growth in many countries, particularly Asia, over the last 2 or 3 decades. So universal health coverage as a part of the social security system can lead people to increase conceptions, because people feel secure in seeking health care, they don't need to pay out of pocket, so they could actually spend monies on other, services or goods that could, stimulate economic growth in their countries. And so these are the development issues. So what kinds of percentage of the GDP spent on healthcare? This morning, people mentioned the United States spend 17, 18% of their GDP on healthcare, very expensive, not necessarily produce good outcomes. This is really a bad examples. But in Asia countries, on average, people, the countries spend 5, 6, or 7% of GDP on healthcare. Thailand only spend 4% of GDP, achieving universal coverage with very good qualities. So this is a good practice. But other countries spend 7 and 8. Not many people spend more than 10% of GDP on healthcare. Probably Germans, other European countries spend a little bit more than 10%. But in some countries, they spend too lower percent GDP on healthcare, like Laos, People's Democracy, they only spend about 2 or 3%. So this is a very, many people already see these, figures. Just to let you know, when we talk about universal coverage, we talk about the 3 dimensions. We talk about the population's coverage, who is covered. And we also talk about which services are covered. And we also talk about financial protections by the different, schemes, payment schemes, health insurance schemes for the peoples. And the different countries have adopted different strategies. For example, in some countries, there more emphasis on the population coverages, but they haven't done adequately in terms of service coverages. In some countries, the financial protection is very limited. So this really depends on the values each country has. Some countries see healthcare is a conception. Other countries think healthcare it could be solidarity of the societies. So this book is just shows when in a particular financial mechanism cover only 50% of population, only cover 50% services, and only offer 50% of financial protection. So this just to give you an impression that we're talking about universal coverage, not just the population coverage. There are other 2 dimensions here. Stage of achieving universal coverage. 100 years ago in Asia, there were no problem countries where there are any financial mechanism put in place to help the people to get access to health care. Now, almost all the Asian countries have more, one way or another, to develop some financial mechanisms to help the people to get access to health care. So the early stage is just the absence of financial protections. All the peoples paid for their health care out of pocket. Then they move to the intermediate stages of coverage. So mixed communities, cooperative and enterprise-based health insurance, and maybe social health insurance for the formal sectors, or limited tax-based financings. Then the final stage is universal coverage of healthcare using either tax-based financing mechanism or social health insurance, or mixed of tax-based financing and various types of health insurance. So this gives you some just overall pictures about different stages of developing or advancing universal health coverages. So over the last decades, lots of countries have done very well in terms of achieving population coverage by different financial mechanisms. For example, China in 2003 or 4, the percentage of people covered by different health insurance only probably just 20%. Now it's almost reached the 95 or 97% of population covered by 3 mainstream health insurance schemes. Korea, they started a universal coverage scheme in the early 90s, 92. They passed the health insurance law. After a couple of years, they achieved the universal coverage. And Vietnam also doing not too bad. Now, Dr. T will give you presentations later this afternoon, and Vietnam has now covered about half of the populations. And Mexico is now almost universal coverage. So these are different countries in a different stage of advancing universal health coverages. So what I want to talk today is due to the different in the context of each countries, and different country has adopted different strategy approaches towards universal health coverage. Mexico, Thailand, these middle-income countries have implemented a universal health coverage strategy with a very good balance between the breadth, universalities, and the depth services. China's rural health insurance, they call the new cooperative medical scheme, focused on the breadth first, universalities first at early stage, then expanded the depth services from inpatient care to the outpatient services. Vietnam has taken a different approach. They focus on the depth services packages good, adequate, while taking a slowly, step by step, to increase the population coverage. Many Africa or low-income countries in Asia, due to limited financing or human resources available, they focus on the universal coverage of selected services, such as malaria control, TB, HIV/AIDS, maternal and child health care, immunizations. So as a whole, different countries, due to a different socio-economic different level or different system context, they have adopted different strategies. So often, countries have adopted incremental approaches. For example, in Mexico or Thailand, the earliest stages, they have covered people's working in the formal sectors, then expanded to the informal sectors with the financial support from governments. India, there are a number of the health insurance schemes. One scheme called the RSBY covered the population living in poverty. Vietnam, 20 years ago, they had two health insurance schemes. One is the compulsory health insurance, one is the voluntary health insurance schemes. The voluntary health insurance in Vietnam has not been very successful in terms of population coverage. And compulsory health insurance is covered. First is employee in the formal sectors. Then they have, a prime minister's decrease health care financing for the poor. So the poor people in Vietnam has been covered by compulsory health insurance with the full support from government. And in recent years, Vietnamese also, start to use government money to subsidize the near poor, they call the near poor people, to participate in the compulsory health insurance. So that's another step forward towards the universal health coverage. China, Ghana, Philippines cover all target population within a short period. They focus on the population coverage instead of services coverage and financial protections. Sri Lanka, Malaysia follows the British National Health Service model using tax revenue to provide all the population with basic primary health care. Cambodia and Laos covers employee in formal sectors plus the poor using the so-called equity fund, many supported by donors. So these are the informations telling us who are the first targeted by different countries. This is a little bit detailed information about coverage rates and who are covered. China have now reached 96% of the population covered by 3 health insurance schemes, 2 in the urban areas, 1 in the rural areas, almost all the populations. Thailand, 100%, Mexico also 100%, Vietnam, 42. This is, probably is out of data. They now is reached about 55 or 60. Dr. T will give you updated information. India still struggling, and Philippines, in terms of basic health care, they have a high population coverage. Kenya, Africa is lower. Korea, or as I said, already 100%. Taiwan is a very good models for Asia countries. I remember a couple years ago, I gave a talk in a conference in Hong Kong, and a number of the journalists asked me which model in Asia is the best. I said it's very difficult for me to who's the best, but I think the Taiwan's model is, relatively speaking, have lots of qualities. The next day, when Hong Kong newspaper said, the WHO official said, Hong Kong should learn Taiwan, it will cause lots of embarrassment. You know. I never said that, you know. Kyrgyzstan, you know. So this is just to give you some information. The second I want to talk is which services. What services are first covered? The schemes in Ghana, Indonesia, Thailand, and Vietnam offer, relatively speaking, a comprehensive packages, including preventive, primary, hospital care. But the schemes in rural China, India, Kenya, Philippines, they initially only covered inpatient services, hospital care. And now they are moving to the expansion of services benefit packages, including primary health care. So it's, in terms of design of service packages, different countries have adopted different approaches. So new rural complement scheme, RCMS in China, mostly inpatient services. Now some places, provinces now expanded their service package to outpatient services, particularly with chronic conditions. There's some preventive cares, catastrophe illness. Thailand, comprehensive. Mexico is comprehensive. Vietnam is also very much comprehensive. India, there are a number of the schemes in India. RSBI only cover secondary inpatient care. So these another examples about which services are covered by Philippines, Kenya, Malaysia, Taiwan. I don't want to repeat. Third dimension is financial protections. What level of financial protection different countries or different schemes have offered? Overall speaking, out-of-pocket payment as a percentage of total health expenditure and the reduction in OPP is a very important indicator to measure financial protections. Ghana, Indonesia, Vietnam reported 4 to 6% reduction from pre-reform levels. India, Kenya, Nigeria, Rwanda had a smaller reduction of 2 or 3% in out-of-pocket payment. Philippines actually increased out-of-pocket payment after reform. But what I want to emphasize here is reduction in out-of-pocket payment as a percentage of total health expenditure may not be necessarily reduce financial burden of healthcare placed on service users. I'm sure my Professor Wu, the next speaker of this session, will give you a nice chart, I guess, about significant reduction of out-of-pocket payment in China. China reached a peak around 60% in the early 90s. Now the OPP as a percentage of total health expenditure in China reduced to 37, 38 recent years. So Chinese government are very happy, say we achieved, these kinds of policy objectives reducing the OPPs. This chart just show you, different countries have different, percentage out-of-pocket payment as a percentage of total health expenditure in 2008. Taiwan is good, 15%. China in 2008 is 40, now is 37. And on average, this Asia country is about 40 or 50 or some near 60. Why I said the reduction in out-of-pocket payment as a percent of the total health expenditure not necessarily reduce the financial burden of healthcare placed on the service users. Let us look at the next figures. That table shows the out-of-pocket payment per capita as a percentage of average annual household living consumption expenditure per capita for the Chinese rural population. In 2001, on average, the rural household in China spent 5.6% of total household living consumptions. Now, 2011, the percentage rising to 8.4. Yes, it is true OPP as a percentage of total health expenditure declined, because of a rapid increase of government investment in health. But due to the rapid cost escalation of care in China, particularly rural health facilities, the financial burden placed on rural population in China did not actually decline. This table shows you this. So we should look at this kind of issue in a comprehensive way, not just look at the OPB as a percentage of total health expenditure. Just this example gave you some evidence. So lessons, what lessons have been learned from developing universal coverage for Asia? For me, I think the political will for universal coverage is very important, but not sufficient. Adequate financial and human resources are required to deliver universal coverage policy objectives. I remember 1997, that time the Central Committee of Communist Party China had a very high-profile conference on health development, 1997. They also, at that conference, they advocated China should re-establish rural health insurance. However, in that conference, they didn't committed any financial resources to support the western and central part of China. So after 5 years, nothing happened. But the second conference, National Conference on Health Development, sponsored by the Communist Party and the State Council in 2002, at that time, they advocated the establishment of rural health insurance with the financial support given to the central and the western part of China. So since then, the universal coverage has been kicked off in China. So that's why I think the political will is important, but you got to also, to have concrete money put on the table. Second, I think many governments have shown if you really want to advance universal coverage, government should financially subsidize the poor, as Vietnam is doing, or China is doing, or Mexico or Thailand doing. The poor people are not people working in the informal sectors to participate in the health insurance or prepayment schemes. Without government support, it is extremely difficult to help the poor people to participate in health insurance. Vietnam's voluntary health insurance is a typical example. When government didn't subsidize the poor or near poor, these people wouldn't participate in the health insurance. When the Vietnamese government started to subsidize the poor and the near poor, they started to enjoy the health insurance policies. And also in the economic development level, it's important to achievement of the universal coverage, but lower GDP per capita does not mean universal health coverage policy cannot be developed, implemented. Sri Lanka is an example, Cuba, China during the 60s and 70s. People usually think the cost of inpatient services is very high, often in the catastrophe expenditures. So many countries, when they design the health insurance, they always think of inpatient services. So the insurance policy would cover the inpatient service first, like what China did for the rural health insurance. But it's not necessarily true. Compared with inpatient services, outpatient services and the drug cost attributable to the chronic disease can be more debilitating than inpatient events. So coverage of primary preventive services is expected to yield greater gains on population health than inpatient services. We have lots of evidence about this. And also, service deliveries. Services can be provided by the public or and the private sectors. Competition is very healthy exercises. And the third party should use effective purchasing means to make a service delivery more effective and efficiently. There are another lessons learned. When countries start the health insurance schemes, they usually have a number of different schemes with different packages and policies, but at the end of the day, they try to merge in different pairs. So this is often a trend to merge multiple health insurance pairs to a single pairs system, as many countries and regions have done, Korea, Taiwan, making the universal coverage policies or system more efficient, effective. as said, significant reduction in out-of-pocket payment as a percentage of total health expenditure has been seen in many countries, but it is not necessarily decrease the financial burden of healthcare. If cost escalation of healthcare could not be adequately controlled. I see the programs, the colleagues from Georgetown University will talk about how to control the cost escalations under the universal coverage healthcare schemes. So I'm actually looking forward to listening to these topics. And multiple second and the next is a multiple sectorial cooperation would have to be developed to achieve policy objectives of universal coverage. Universal coverage is not just health sectors in the matter. Without collaboration with social securities, Ministry of Financing, you couldn't actually make this successful. Leadership from cabinet levels, state councils, prime minister's offices is essential for successful implementation of universal health coverage. Finally, we need to talk about monetary evaluation. Monetary evaluation is critically important in the process of advancing universal coverage. And WIPRO, Western Pacific Regional Office, WHO, in its strategy for financing healthcare, proposed these 4 indicators that should be used to monitor, evaluate the performance of universal health coverage. One is out-of-pocket payment should not exceed 30 to 40% of total health expenditure. Total health expenditure should be at least 4 or 5% of GDP in Asia countries. Over 90% of population should be covered by prepayment or risk pooling schemes. Close to 100% of voluntary vulnerable population should be covered by social assistance and a safety net program. So these are the 4 key indicators proposed by the WIPRO to monitor and to evaluate the performance of universal coverage. But I personally think this is not enough, as the reason given earlier. We should probably develop some indicators on cost escalation, quality of care, and others. That's also very important and crucial. So I'll stop here. Thank you very much for your attention.